I was asked initially to talk about distance health, virtual health, and shared medical appointments in 10 minutes, and that's not quite possible. So I'm going to give you kind of a quick overview. I will tell you that one of the Watsons is actually at the Cleveland Clinic, and IBM has just created their AI corporate headquarters for medicine on our campus. So it hasn't been that successful, actually. It hasn't been that successful at MD Anderson yet either. But I'm sure it will be. So I have nothing to disclose. So these are my objectives. I think that the main reason all this is happening, why it's happening so acutely in healthcare, is because there are external forces that are basically forcing us to do this. Increasing healthcare costs, complexity of disease, expectations of patients, payers, government, everybody is interested in healthcare being more value-based, and technology is actually our enabler. And so we use technology to help us do this. And really it gets down to the value equation. And I think most of you realize this in business, is that it's not just price and cost, it includes outcome, and that's what gives value. And we're pretty good now at looking at price and cost. We're fairly good at looking at outcome, but we don't combine them very well to look at value. And virtual medicine is changing. What is it? It is the transfer of electronic medical record, video, sound, image, EMR, etc., from one place to another. And basically a picture's worth 1,000 words, which was what was presented with the dermatology activity, and I'll talk a little bit about that in a second. What it will allow us to do is to deliver smarter, more affordable, and more accessible care. And I think the word more accessible is really important. We are now looking at drones to drop off medications to people in the inner city who can't get into our visits. And we're using Uber to bring in people who can't get in for their operations or whatever, and we're paying for it. Because from a population health standpoint, it really improves our ability to manage the patients around there. So sometimes this is easy, and candidly, sometimes this is hard. And I'll talk a little bit about some of the barriers that we hit while we were doing this. My stopwatch stopped, so I'll have to kind of go by. So telehealth definition is any caregiver or patient interacting both when both are not in the same location. And why healthcare? Patient commands, convenience, improve access, managing expectation, and it's inevitable. So if you're not participating in telehealth at this point, you will be in the next 2 years. In fact, you probably are and don't even realize it in some case. And everywhere you look, there's a number of people that talk about the dramatic increase in telemedicine and how it's on the rise. This is from Medical Economics. And this shows pretty graphically what's happened. So in 2014, only about 50% of institutions were using telehealth, and in 2018, it was up to about 80%. So what are the digital health tools? These are the ones that we have. So these are kind of the standard tools we use, both for the patients and the providers. In many cases, the patient and provider are integrated in what they do. The one thing that we've had for a long time has been a program called My Consultation, so people can consult us from anywhere in the world, and we can use their technology, integrate it into our technology, and give an opinion. So really, a good way to look at it is two different ways. Synchronous programs, and so that means that the telehealth is going on at the same time in every one of these places. So it's really a live audio-visual between the caregiver and the patient. It can be on the inpatient side or the outpatient side. On the inpatient, it services our own enterprise for better access to specialists. What's happening is as we've expanded and grown, we can't keep up enough specialists to be able to cover all of our hospitals, for example. So many of our services are not, so otolaryngology is not present in, Roy, how many? We're only in 3 or 4 hospitals out of 13 in the system around Cleveland. And we really have to find a way to be able to provide that. And virtual rounding is something that's been going on for some time. So we actually have these centers called e-hospital. It's primarily access to critical care patients because they have the same issue. They can't put intensivists in every one of our ICUs. It's just too expensive. It's prohibitively expensive. And many of the things they do are just monitoring related things and orders. And almost all of this can be done digitally. So this provides, we actually have a center that people sit at, and then they access patient information, telemetry, et cetera, from these other places. So in the e-hospital, the clinicians monitor ICU beds, they constantly rescore patient acuity, and then they direct the clinical teams that are on site in the various hospitals throughout the system. So remote telemetry is probably the easiest because you really don't need to be there to be able to assess what to do with telemetry. Many of the decisions are made directly off the telemetry machine. And so it allows us to be 24/7, somebody available to respond to any alarms that go off in telemetry. E-consultations is a good way to better manage your patients with provider-to-provider communication. So it's an internal process. We actually get RVUs for this, even though we can't. And in many cases now, the payers are allowing us to bill for an e-consultation. It cuts down on unwarranted visits, so you remember all those nights you have to go into the emergency room for the nosebleed that stopped 3 hours ago. And it allows us to take a look. And some of the things that were just shown to you by Joseph are some of the technology we use. And it frees up the specialists again. So here are the consultations that we've done in ENT and how it's increased over the years. Our primary one is with our residents. And so our residents carry this little device. It attaches to their iPhone. Their iPhone is Cleveland Clinic-based iPhone, so it's HIPAA compliant. So they can either record live, or they can record it and send it to us. Or if we go on consultation rounds, we no longer have to actually look and redo the scopes on the patients in order to be able to determine what was wrong with them. Virtual Medicine Clinic uses sophisticated real-time technology to connect Cleveland Clinic physicians with patients requiring specialized consultations anytime and anywhere. Facilitates this collaboration between physicians and interaction, again, with the specialist. So we actually have this ability to communicate with our patients anytime, anywhere. I have an app on my phone that communicates with any of my patients when I need to, and it automatically goes into the electronic medical record, and they can actually download images through my app into the EMR so that it is documented within the EMR. And it allows for billing, which is an interesting thing. So we bill cash for many of our patients. If you're coming from Pennsylvania and we charge you $45 cash for a short e-visit, it's a lot better than driving from Pennsylvania to Cleveland and parking and all the other things that they do. And so this is really expanding. The patient can be seen at anywhere really in real time, and then secure technology, and then the physician can communicate with the patient in any other location. The virtual medical experience is basically a big part of what we do. We can interact, we can do the telemedicine type activity, or more importantly, we can interact with these patients. And again, it's an app-based protected program and password protected. It's easy to navigate. We can use this for inpatients. So if an internist sees somebody with a urological problems, they can examine that problem live so that the urologist can take a look and make sure that they can help. And then the person that's observing this can direct the nurse, the technician, through the exam, seeing and hearing and diagnostic details at the same time. So these are some of the things we do with the virtual medical experience. We actually take photos and images and so of the larynx or of the ear, and it allows us to make a diagnosis and aid in their care. And in many cases, particularly in medicine and cardiac, the examination can be done by a nurse with the physician participating at the same time and not actually being in the room at that time. And then you conclude the exam, the final questions, physician interactions, and then appropriate future treatments and plans, and then it goes into the EMR. So what are the issues? I mean, licensing is an issue. So I have to have a California license because California requires that if you see more than 6 patients a year in California, which I am because it's a virtual visit, I have to have a license. So I have a California license, and I'm never going to practice in California in order for me to do e-visits and e-consultations. Payment can be an issue. A lot of the payers are not paying for it. So the primary place we're using it in our practice is in global fee period post-operative visits. So somebody that's got an incision you have to check, it's within the global fee, why bring them in? It's a 5-minute visit rather than taking up the room, etc. It does require capital expenditure and equipment, and it does require internet connectivity, and candidly with some of our patients that's really sketchy. You know, they can't figure out how to use an app, they can't figure out how to get connected to the so particularly with the older generation, it's a little bit more difficult. We have an inpatient virtual rounding system with the AV connectivity, allows the surgeon to round on patients in different hospitals when they're not there, so they don't have to see the patient live every day. And e-consultations are a convenient way to secure and receive care from Cleveland Clinic from the comfort of people's homes. It's simple, it's easy. I mean, it really is easy. It's fantastic. I'll show you in a second how we use it in ENT. We utilize care pathways for a lot of the things we do. So a number of these patients that contact us for an e-consult or whatever, we actually participate with them based on pure care pathways. So do you really need to see a patient with acute sinusitis? It's all care pathway driven, right? Do you even need to look in their nose? 7 to 10 days, purulent runny nose with a couple other symptoms, and you treat them. And you treat them with an antibiotic. So that really, and it's relatively easy for people to enroll. Facility-based virtual visits expand on the access and delivery of high-quality care. This is kind of what they see from a virtual visit standpoint. We do it in ENT, we do wound assessments, we do post-tonsillectomy checks, we don't see post-tonsillectomy patients anymore, follow-ups for patients who live far away, answering complex questions for patients, and determining if a patient needs a live visit. And now we have remote monitoring, so patients actually can wear their remote monitor and we can keep tabs on them for blood pressure, weight, temperature, pulse, chronic conditions, etc. And then you have the asynchronous, where it's image upload portal. I mean, most institutions have this. Some other place uploads the images, etc., and we go from there. Or wound management, where they send a picture in and you call them back and tell them what you're going to do in relationship to that. And then image exchange from outside institutions into ours so that our people can actually do the interpretation. And dermatology was already mentioned. I mean, and now in dermatology for melanoma, that the app-based pictures are 98% effective in ruling out a melanoma. The dermatologists are only about 98% effective in ruling out a melanoma. And it allows for some other things in relationship to complex medical problems. So I'm going to end with this. And this kind of goes back to your original presentation here. So the world is too big for us, too much is going on, too much violence and excitement. Try it as you will, you get behind in the race in spite of yourself. It is an incessant strain to keep pace and still you lose ground. Science empties its discoveries on you so fast that you stagger beneath them in hopeless bewilderment. The political world is changing so rapidly that you're out of breath trying to keep pace with who's in and who's out. Everything is high pressure. Human nature can't stand it anymore. That was in the Atlantic Journal in 1833. So despite the fact all this is happening, they felt the same way just at the beginning of the Industrial Revolution. So thank you.